Before starting, I would ask everybody to mute because I have a terrible background noise. So if everybody can mute their microphone, maybe the audio will be better for everybody. And I'll try to share my screen.
The mute button is down on the bottom left of everybody's panel.
Okay, can you see my screen? Yeah. Okay, so I'm gonna tell you some very preliminary data. This is a preliminary report of this action that was a joint action promoted by the Italian Neurological Society and the Italian MS Society together with the Italian Registry. So this is the name of the project, that is MASC-19, Multiple Sclerosis and Covid-19. This project has two objectives, a short-term objective and a longer-term objective. The short-term objective is is to cover the very urgent need to collect information about patients with MS who got the infection. And as Italians, since unfortunately the infection started very early here, I mean, we thought that it's very urgent to try to give other countries some information about patients with MS. Then we have a longer term objective. The idea is to flow this data into the Italian registry to obtain also epidemiological information in a sort of case control study. So we will need information on all the patients in Italy with MS to have a comparison. So we set up very quickly a method to collect data. So we set up a case report form that is a paper CRF, collecting data about the history of MS, of the positive patients, but also of suspected cases of COVID-19, because, you know, at least in Italy, just the patients with very worse symptoms are tested. So we have many symptomatic patients who don't have the test. Mm-hmm. We also have a web-based platform that is ready. We're testing it internally so that we can switch from the paper case report form to a web-based platform that, of course, can be shared to everybody and also to, to other countries if needed. So I will report the first CRF we collected. Today we have in our data set 143 patients from 31 centers. About 90 centers in Italy were contacted, all MS centers, and we received positive or suspected cases from 31 of these centers. So up to now we have 60 confirmed positive cases and 83 suspected cases. Just to give you an idea, in Italy, now we have 100,000 positive cases. So, I mean, this is just to give you a very rough idea of what's happening. I mean, we do not pretend to have detected all VMS positive cases, but hopefully most of them. So with 60 confirmed positive over 100,000, I mean, it doesn't seem to be a signal of an increased prevalence of MS among the positive cases. Up to now, 5 patients died. Up to today, all the patients who died are 5 were patients in the progressive phase of the disease, all secondary progressive and 1 primary progressive patients. There was also a young patient, a female of 55, who was secondary progressive in rituximab, and the patient who was in dimethyl fumarate. The other 3 patients were not under treatment because of their secondary progressive phase. And finally, this is the disease phase. As you can see, this is the sample we have. You can see that in the positive cases, there's a higher prevalence of progressive patients as compared to the suspected cases. So we must have in mind that the positive cases are those with the worst symptomatology, with the worst, with the most aggressive COVID disease. So among them, there are more progressive patients. And this is the distribution of therapies across the positive and the suspected cases. I mean, it's too early to draw a conclusion from these numbers because you see the numbers are still small. Anyway, we can't see up to now a clear signal of an increased risk for any of the therapies. I mean, the distribution is pretty homogeneous between the positive and the suspected cases, and it's not so far away from the distribution of the therapies in the MS population. But anyway, it's too early to draw conclusions from this preliminary data. We are collecting patients at a high rate. 2 hours ago, the number of collected patients was 160. So we do hope to be able to give some more relevant information in a few days. And I think that's all from my side. If you have questions.
Thank you, Maria Pia. I think maybe what I suggest we do, I suggest that the people who have accepted to share information from their registry give an overview of what they have to share with the group, and then we open the discussion to everybody.
Sure.
What we're going to do, because some people have mentioned on the chat that there's a fair bit of background, maybe Fabienne, you can mute everybody, and then we'll unmute the next person. So I think the next person was going to be Maria Troiano. Maria, are you around?
Yes, here.
Fabienne,
Oh my
please
God.
mute everybody. We'll let Maria unmute.
Hi. Hi. How are you? Okay, do you hear me?
Yes. Yes.
Yes. So I would like to update you on the initiative of the Italian MS registry. As you know, in Italy, the Italian MS Society and its foundation and the Italian Neurological Society have set up a large program to address this issue, unfortunately. This program includes initiative in the short, medium, and long term. As mentioned by Maria Pia Sormani, a dedicated web platform. I can share with you no, anyway, I can explain without any slides, because just 2 slides. As mentioned by Maria Pia, a dedicated web platform has been developed to collect data in this international project. But in the meantime, the Italian registry can be collected also the information on COVID positive patients in the adverse event section of the registry. So just to analyze these positive cases in the context of a large number of information on the clinical history of patients, treatment history of patients. But tomorrow we will have a teleconference with the scientific committee of the Italian registry, in which we will discuss how to include a module within the Italian registry, similar to that already presented by Maria Pia Sormani. So just a part of that module, just the part of the module including information on the COVID severity, code outcomes, and so on, because all the other information on demography, on the clinical course of the disease are already collected in the registry. So for the project of presented by Maria Pia Sormani, the CRF will be linked to the Italian registry. And I hope that together with Jérôme Desais, I don't know if Jérôme is in the teleconference, we are discussing to share this module also with the other 5 registries in the big MS. So, of course, we need now urgent response to this issue, but I think that in medium and long term, we will provide important information on, also on epidemiological data. So this is the state of art of the Italian initiatives.
Thank you, Maria. So maybe Christine, are you around, or people from the LEOS group to give us an update of the situation in Germany? So, Christine, are you around? So,
yes, I'm here, sorry. And I try to share my screen.
At the moment, we're viewing Maria's screen.
Okay, yes.
So Maria.
Yeah, and
Okay.
share. Excellent.
Yep.
Okay, I try again. Okay. Okay. Yeah, hello everybody. I would like to present the LEOS survey. It's actually not a MS registry, it's a general COVID-19 registry, but we managed to bring MS as a comorbidity in the registry. So if our patients end up to be documented by most likely intensive care doctors, that they are infectious disease doctors, that they are captured. So it's an international multi-center cohort study. Here you see the countries. It was thought to be a European initiative, but it's has already some sites out of Europe, and it's for hospitalized patients and patients who receive also ambulant treatment in all stages. It only started 2 weeks ago, and it tries to identify predictors of good or bad predictors of outcomes. It is anonymous, so there is no informed consent needed. So you can include children, unconscious people, or death. And as I said before, MS is in as a comorbidity, but with only a very minimal data set, not as extensive as it is. Data are captured in all of the MS registries initiatives. There are of course, the MS drugs before the diagnosis. And we also managed to bring in a questionnaire with other immunosuppressive treatments we use for other neuroimmunological diseases. But other than MS, only myasthenia is specified as a neuroimmunological disease. And so this, sorry, here you see the data from yesterday. They, if you are in the team, you get an email every day how many patients are enrolled, and they started only 2 weeks ago, at least, to open the platform, and there are 281 patients, 5 with multiple sclerosis, and they just gave me the data today. So the MS patients are the little brown column, and I asked for the medications of the 5 patients. It's like in what Maria Piazzomani showed in the much bigger Italian cohort. It's one of each drugs. It's alemtuzumab, one natalizumab, teriflunomide, DMF, and I forgot the 5th one, fingolimod. So we asked for MS and relapse treatment. We asked for selected lab values, leukocyte count, if available, B cells and IVIG levels. We have the EDSS stratified at baseline and at recovery. And other than that, there are only COVID-19 question. And I think it's easy to get an ethic approval. So in Germany, with the anonymization of data, it only takes 24 hours ethic committee to give you in this pandemic situation ethic approval. And it's really easy to enroll, and it's also easy and I think motivating to get information. They are really good to share what they already have. It's not a direct MS registry, but it's also, I think, why it could be interesting for this group in countries where there are no registry. All the infrastructure is set, and it's easy to document patients. Thank you.
Thank you, Kirsten. Is Mar, are you still on the call to give you to give us an update on the Spanish situation?
Yes. Hello. I'm here, and we are. We had a call on Monday where other people from Spain also connected, and our colleagues from also were connected, and from different parts of Spain. So the situation is not any better from last week that we connect. We are, our MS patients, however, are fortunately doing, we have the impression, this is obviously very subjective, that we have the impression that they are doing pretty well. At our center, we have a small record of the patients that have probable COVID or confirmed COVID. We have, I think, today like 32 patients. Some of them on the different drugs. The majority of them are doing well. They are. We don't have one patient on rituximab. We just knew that he died, but we have not already confirmed the information about what happened. So we are not sure with the, but it may be because these days the majority of people that are with fever and with symptoms, they have probable COVID as the most probable diagnosis.
Sí, los chinos se ponían fiesta delante.
Thank you, Mar. Is Lisbeth Peters on the call? So Lisbeth, if you're on the call, you may want to unmute yourself, and maybe you can use the chat to tell us who Fabienne should unmute. Okay, so if Lisbeth maybe is not on the call, so
I
Lisbeth.
think she is, but
She is.
yeah, I'm trying to find her.
Hi, I'm
Hi.
here. I didn't, sorry, I didn't know that it was
Good.
my
And so
turn.
we
Apologies.
can remute everybody else because there's been
Okay.
some background noise. So thank you.
Okay, yeah. So I just didn't know it was my turn. So sorry for that. All right, so I'm trying to share my screen. I don't know if it's actually working.
Yes.
So, okay, so it's just one slide that I have. So that was the intention, right?
Yes.
Okay, so my name is Lisbeth Peters. I am the chair of the MS Data Alliance Initiative and also the coordinator of the Global Data Sharing Initiative, which is a joint initiative between the MS Data Alliance and the MS International Federation. And it was specifically because indeed that the previous initiatives, they are clearly showing the need that is both on a short term as well as a long term, and indeed integrating all that data collection procedures into the registries and data collection initiatives has a lot of advantages. The MSIF was actually contacted by several of these initiatives that were pioneering the COVID-19 data collection, amongst indeed like the Musk initiative that Maria Pia originally already explained in the beginning. And then already the UK registry had launched an initiative, and then MSIF wanted to formulate recommendations on aligning data collections from the beginning onwards. The advantage of doing that is that downstream data sharing and collaborative efforts will actually be less time consuming, and also that there are like guidance for people who would like to do data collections on COVID-19 in people with MS. And the Global Data Sharing Initiative, first of all, is not a registry, it's a data sharing initiative. One of the key things of this initiative is that we are not in competition with all the existing initiatives, explained also some examples before. The idea is actually, okay, all these different initiatives, how can we empower them? And how can we make it possible that collaborative research can happen so that actually joint insights can happen on a combination of all those data sources. And that's why we propose an initiative that tries to facilitate and empower the local initiatives as much as possible. And we do that by formulating recommendations for what we call a COVID-19 core data set. So that is actually a list of variables that should be the common denominator, or should be trying to be the common denominator across as many different initiatives as possible. And that core data set was actually agreed upon by a global task force, which was actually a group of people representing the pioneer registries as well as some major umbrella organizations. And we agreed upon that core data set working on top of the pioneer initiative, like the Musk initiative, which was one of the major baselines for drafting the recommendations of the core data set. And the idea is that this core data set, or the recommendations for the core data set, are being implemented in as many different registries as possible, so that it becomes possible to actually have a sub data set of this COVID-19 core data set being exported out of the registries and integrated into a central platform, which was kindly provided by Qmenta, which is actually a cloud-based system that is mainly aggregating and integrating different data sources. And the idea is that different registries that are either clinician reported or patient reported, or the combination of the two, are actually using this COVID core data set and then importing a subset of their registry specifically on the COVID-19 cases or controls into the platform, and that then inside the platform, these initiatives are being combined into a central data set where 3 expert epidemiology group will work on actually generating the combined insights across the different initiatives and learning about the combined initiatives in that. Because we have seen that some people do not want to go to registries for some reason whatsoever, although that we really recommend people to go to the initiatives. We have provided the possibility for direct entry into the platform, but we're definitely not encouraging them, and ideally we have as little records as possible in the direct entry, and all of it goes via the registries and initiatives. But we wanted to empower those people who still would like to do it, but not via the registries. So that's from a very high level how we envision this. So we really see this as a collaborative effort where we are very inclusive. We are going at a speed that is making it sometimes difficult to communicate with all stakeholders, but we really invite everybody to come back with feedback either via email. So there are several contact details on the websites of the MS Data Alliance, which is msdataalliance.com or msif.org, where all the different recommendations for the different stakeholders are being formulated. And I really encourage the group to go and check out the websites as well as start implementing the recommendations or collecting and sharing the data. And of course, I'm open for questions, but this was my introduction.
Thank you, Lisbeth. So I wonder whether, before we start with questions, so I see that Christine Lebrun, you are on the call, but I don't know whether you want to talk about the French registry. Otherwise, I have the slides from Jérôme, so you can unmute yourself if you want to talk. Otherwise, I'm happy to share the slides from Jérôme.
Hi, Emmanuel, everyone. I think that Jérôme sent you the French MS effort, maybe with the 30 cases so far, I think.
Yeah, so I'm happy to share that slide with the group, actually. So bear with me.
So the French MS effort starts about 10 days ago. And this is the effort joined with the French MS Society, the French MS Observatory, and the RCEP, which is the largest patients associations. And so far, the 28 MS clinics are involved in this effort. And we have 31 cases, mostly relapsing remitting MS, and no death, hopefully. We have two patients who have a very, very important form of the disease. The first one was treated with ocrelizumab, and the second one with fingolimod. The clinical presentation was really classic, with fever, fatigue, and cough. And more than 60% suffer from anosmia and ageusia. So I think that's, you have only 2 slides from the group?
Yeah, I have 2 slides, and basically this morning Jérôme told me that now there's 59 patients with MS who are COVID-19 positive or suspected to be. As depending on the country, some of the testing is not broadly available for patients who have milder forms of the disease. And so on this slide that's on the screen now, you can see that except for the 2 patients who are on the, so one is in the ICU and one is hospitalized but not requiring oxygen. The bars that have all the colors are actually showing the combination of different treatments for patients who are not hospitalized. Some have limitation in their daily activities, some don't. And you can see basically that, you know, there's patients on all the disease modifying therapies we're using.
Yes, today in France, it's really difficult to have a test for some patient for many, many reasons. So we probably underestimate the number of cases, but we have patient-reported cases, so we have to double check if we can test them.
So is there anybody, so maybe, I don't know whether anybody wants to talk about the current efforts regarding the registry in the US. I don't think there's anybody from the National MS Society on the call, but I may be wrong. So I don't know, Myla, if you want to discuss, or otherwise I'm happy to just give a quick update.
Yeah, I think if you want to go ahead, Bruce had mentioned getting on the call. I don't know if he's here.
Yeah, I don't know.
See him on the list. Okay, why don't you go ahead, and I think he sent a follow-up email.
Yes.
Just maybe to be aware it's coming. Oh, Ruth Ann is able to speak to that issue. She just identified herself. Thank you, Ruth Ann.
Excellent. So Ruth Ann, go ahead.
Can we unmute her? Yes, great.
And I'll try to stop sharing my screen, but I'm having some.
Yeah, Ruth Ann, we just learned.
Can you hear me?
This morning. Yeah, great. Thanks for jumping in. We don't have all the details.
Yeah, so Bruce has been trying to spearhead an effort through the National MS Society, which is specifically trying to coordinate with the Consortium of MS Centers effort. They're of course aware of what's being done through the MS Data Alliance. So although data collection will not be identical, the core data elements in terms of the things that are being collected and using the same categories and labeling for things like comorbidities or outcomes and things like that are intended to fall into the same categories. Amber Salter has been putting together the sort of data collection form into REDCap. It's meant to be anonymous, which would mean it would fall under your US common rule for surveillance and public health efforts as not requiring ethics approval at individual sites. Obviously, if you wanted to go back to charts or do anything that's not anonymous, that's a different issue. But this is intended to be able to allow rapid reporting and sharing of the data for the international effort later. The hope is that we'll also be able to use this in Canada, although we have a different set of ethics rules. We obviously don't fall under the US common rule, but we're going to make some inquiries about that. If it looks like ethics review is required, we're going to see if we can actually do it through a central REB to minimize the amount of effort for Canadian clinicians who might want to participate. So those are sort of in broad strokes where things are.
This is Ajay in Fort Wayne. I think there is a teleconference with Avi Nath from NIH and Ann Cross to set up a MS COVID-19 registry.
Yeah, so Ann,
today or tomorrow.
Yeah, so, well, Ann Cross has been involved in the NMSS working group and has been part of the integration of the efforts by the NMSS and CMSC, so there will be a single registry in the US. The intent was not to have duplication of efforts. So what's been agreed to incorporates the input from both those organizations.
So thank you everybody for the updates. You saw that obviously we have different stages of registries, some producing already some data and some just about to be launched. I think that the good news is that some of the data that we'll continue to get over the next few weeks will be shared with people. I would like to open the microphone now for people to ask questions to the different presenters of the various registries we've heard about. I will read some of the questions that are in the chat as people may want to add more questions or raise their hand so we can unmute them. So some questions were, are the patients currently taking disease-modifying therapies? Or so I think that was about the Italian registry. So maybe Maria Pia, if you're still on the call, you can answer that. Looks like 5 deaths in progressive patients. So you're welcome to answer that.
The therapy that I presented is the current MS therapy. So, I mean, this is not historical, but it's the therapy they are taking when they develop the infection. And regarding the 5 deaths, they are all in progressive patients, and 3 of them were with no therapy. So this is the state of the art. Of course, the progressive patients are older and with comorbidities. Most of them had other comorbidities, high EDSS. So, I mean, they are the most disabled patients. Okay, there's a question about COVID encephalitis, but we don't have, in the current data set, we don't have any signal of that, at least. I mean, I don't think there's a specific item in the CRF for encephalitis, but I mean, usually, I mean, doctors who fill the CRF also write if they see something unusual. So we didn't have any signal of encephalitis.
Thank you, Maria Pia.
In a question about anosmia, there are many patients referring this symptom. I mean, I probably don't have the data yet, but there's the field to be filled, and many patients report this symptom.
So there's another question about prolonged shedding, basically leading to super spreaders. Is that something that the registry can look at? I mean, I expect that probably not, because there's not too much biological information, right? Another question, anosmia in the Italian database.
Yeah, it's a very common symptom, and many patients reported it. Maybe together with other symptoms, but anosmia is really frequent.
I think that in the CRF we need to include these 2 symptoms that currently are not reported. So I think that is an important change that you have to do in this.
But yes, it was already implemented in the new version.
Yes.
Because many patients, you know, there was the field other, and most of the patients were feeling with the anosmia. So we added this box to the possible choices. Yeah.
So I would like to comment. I can?
Yes, you can.
Yes, to stress that we need on this call to discuss that the module, the CRF, should be similar in all initiative, in all data collection, because in the future we can share these data and to obtain important information for the future. Because I think that this big issue, unfortunately, we could in the future have experience with that. So, for example, as I mentioned before, in the big data that represents so far the largest data set on patients with multiple sclerosis, we are discussing to merge data on more than 150,000 patients. And I think that not so fast, but I think that for the future, this is a very important project. So also in the United States, in other countries, I think that we need to follow the same data collection.
Yeah, so maybe Ruth Ann, you want to comment on that? My understanding is that the American registry that will be up and running next week is based on the MuSK19 CRF, but a shorter version. Is that correct, Ruth Ann?
Yeah, so it's very similar to, I mean, it's got pieces of what the MS Data Alliance is recommending, but there have been some additional questions that, were requested in the US. There's also been, careful review of what the World Health Organization was using in their CRF, which is shorter, to ensure it aligns there to allow comparison with other disease populations. So I don't think for the for the core elements, they will be the same. Insofar as we're able to do, there are some things like date fields to meet the IRB exempt thing. We had to use years and not exact dates. Otherwise that was going to push us into a different tier of ethics review. But otherwise, the fields that are collected in common match in terms of the outcomes and labeling. Sometimes there are additional questions, but I don't think that's going to interfere with the ability to combine. It was a very conscious decision to try and ensure there was as much overlap as possible, while recognizing there were some unique questions that were coming up here.
So there are some questions about any information regarding the development of SARS-CoV-2 antibodies post-infection. I don't think we have any answer about that because I think the tests are being set up to be able to measure serologic conversion of individuals. Then there's a question, can we get to look at the questions and data points in each database? So I think that one thing we will strive to do is to try to post on our website, to the International Women in MS website, which is iWiMS.world. We will strive to post as much information and links to existing registries, so people from different countries can join some of the ongoing efforts. Hopefully we can have people who were on the call today give us an update on a regular basis, as we're going to hold these calls once a week. Another question here is, any reporting cases of COVID infection in children or adolescents with MS? And I'm not aware of any, but if somebody has...
No, we don't have any, we hadn't any child in our data set. Also, I mean, we are in contact also with pediatric hospital, but nobody reported a case of a child with MS, at least up to now, but
another question is, any pregnancy...
Lauren wanted to talk.
Well, just...
Sorry, Emmanuel.
That's okay. There've been a couple of cases that I already know about in the US of teenagers who are COVID positive or highly suspected.
There was a question about pregnancy. So I don't know whether there's any MS patients who are pregnant who have been infected, but I know that there's been a fair amount of data on pregnancies in general from the Chinese cohorts that were published, I believe, in the New England Journal of Medicine in the past few weeks. Another question, do patients with lymphopenia have a more prolonged course of severe COVID infection? I think that maybe, I don't know whether from the data in the Italian registry you have...
we examined the issue of lymphopenia, but there are just a few cases of patients included with lymphopenia, and they don't have any evidence of a worse COVID course, but the numbers is very small. It's about 12 patients, so it's a very small number. But anyway, these 12 patients are, I mean, there's no sign of a worse disease for them, at least.
So were there DMF patients? So there were DMF patients in all the registries that were discussed. So from the Italian to the French registry, and I think in the German one too.
But is the question related to lymphopenia or in general?
Dimethyl fumaric acid, I think.
In our database, most of the patients are in DMF. But it reflects the distribution of therapies in the DMS population.
So can I say, based on the small amount of data we have now, that it doesn't look like there's a signal that COVID-19 infection is more frequent in MS patients on DMT compared to the rest of the population? I know that the registries really don't answer clearly that question, but doing the math based on the numbers in Italy and knowing that a fair amount of patients who are infected are actually not tested, is it kind of reasonable to say that for now we don't have any signal of an increased infection?
This is something that we can say with caution because we don't know exactly the denominator, and also we are not sure to have captured all the positive MS cases. If we compare the positive MS cases we have so far with the positive cases of patients in Italy, there's no signal of an increased possibility to get a severe infection, because the positive cases are those with the most severe infection, because there's a reason why they are tested. So they're tested when they get to the hospital. It's difficult to get the test if you're at home and you just have a fever. So those who are tested are the most severe. And up to now, we must check because, we are not sure to have captured all DMS positive cases. We must try, we must check that.
Maria Pia, I am Celia from Spain, have the same impression like you. We have now 700 patients in our hospital, yeah? And MS patients, there are only 2 hospitalized. And we have only 12 cases. That is the same like you, yeah? We have only the severe cases or that they have luck, they have a test, and the others that they are at home, they have no test. But we ask a lot of questions to be sure that they are infected, and normally they are infected. So that we have the same impression for the huge number of patients that we have in the hospital, we don't see an increase. So we have thought at the beginning that we can expect that many of our patients, they are with infections, and we don't see this. And our patients, they were coming to our hospital until the middle of March, that there was infection there, and many of the physicians, we were infected, but the patients, they were not infected. So that we have the same impression like you, that they have an increase.
If I can add something, this is also our impression, and we are now in the THEMCAT, we are now living also with our hematologist colleagues who have been transferred from the general hospital to our building because the place where they were located has been transformed into an ICU. So we have now many patients who come to this hematological day hospital. And talking with our hematological colleagues, they also told us that their impression was that the number of infected COVID patients was not so much increased as they were expecting. And this is also our impression with MS patients.
And then, so that's for the risk to get the infection, and then the other question, but I think we can't really answer that now, but I'm sure that in the next couple of weeks, we'll have much more information about the effect of being on a specific disease-modifying therapy or having, for example, lymphopenia relating to a specific disease-modifying therapy, and whether it's associated with an increased severity. So another question we have here is, do we have data from countries that test more asymptomatic patients? And I don't think we do in terms of patients in Sweden or Iceland.
Emmanuel?
Yep.
Yeah, hi, Jeanette. If I just can briefly talk about the Australia-New Zealand experience while Annika probably deeply asleep at 3:30 in the morning. We only have 4 cases, so we collaborate, as you know, very closely in Australia, and 4 cases in Australia and New Zealand, 2 of which are on ocrelizumab, 2 are on fingolimod. The one on fingolimod, of course, lymphopenic, the ocrelizumab with normal lymphocyte count. They're all 4 have recovered. The cases represent the guidelines for testing as in the other countries. So these patients were all at home. They were tested because they came from overseas, had travel or exposure to other known cases. That's the guidelines for testing. So we test quite frequently, but certainly not in the asymptomatic patients or mild symptomatic. So that you do need to have traveled or be in contact. So that's what our case cohort represents.
So I have a statement here from Elizabeth in Norway, who said that they are testing many individuals in Norway, and so far she knows only about 2 MS cases that tested positive for COVID-19. Another question is, what is with relapses after disease? And I think that we probably don't have much information about that. If people from Spain or Italy or Germany want to chime in, I think it's too early to answer that question.
Yeah, the follow-up is too short still.
I think, Manuel, that another important question that we should answer quickly is to evaluate the risk factors and then the long term and the follow-up of these patients. And the risk factors can be evaluated only within a registry because we need to include patients with the same characteristics that do not develop COVID infection. So I think that this evaluation can be done in a short time, and in the next 2 weeks we could provide some information collecting data from different sources. I think that it is important because to show only a descriptive analysis of the population, infected population, is important, but I think that the evaluation of risk factor can be more useful, helpful for us.
Thank you. So other questions here, have there been initiatives from China, Korea, Singapore, or Hong Kong? And I'm not aware of any for MS or NMO, but if people know of any, you're welcome to chime in. Another question, was fingolimod stopped during COVID-19 infection? And then one, was it restarted? I think that there's really not any clear guidelines of what we should do. So for the Italian and the Spanish patients, or maybe the French patients also, if anybody knows if treatment was discontinued, if they were on fingolimod at the time of the infection.
We don't have this information yet because we have to analyze, the data according to this criterion, and we haven't this information yet.
We have one single patient, and we decided to stop the medication, but this is purely anecdotal.
So we have 2 with fingolimod. Sorry, we have 2 with fingolimod, and both of them, they were with fever and getting not so good, and we have decided to stop fingolimod 2 weeks, and later both of them, they recovered, and we have start with fingolimod again.
And Okay, so then when patient on dimethyl fumaric acid get the infection, would you stop DMF irrespective of lymphopenia? And I think that there's also probably as much information as for fingolimod, right? So in Italy or in Spain, any
We have two with dimethyl fumarate, and in both of them, the lymphocyte count, they were over 1,000, and we didn't stop. In the patients that we have stopped in fingolimod, in both of them, they were around 400. But in the dimethyl fumarate patients, they were, I think, 1,100 and 1,200, and we have decided not to stop.
Okay, so we're at the top of the hour. So thank you very much to all the participants. I hope you found the call helpful, and we hope to have many of you back next week for the next call. We will circulate your link for the call. We will also post the recording of the session today on our website. So if you have colleagues who are interested in listening, there will be the possibility in the next day or two to be able to do that. And I want to thank our Australian colleagues who got up in the middle of the night to join us today. So congratulations for being that brave. Thank you, everybody. And what we hope to do also, and I don't know whether people who have different registries would be open to share an update of their weekly registry, which we're happy to post on our website also.
Yeah, Emmanuel, we can share our CRF for, any kind of use. If people want have a look at what variables we are collecting, we can.
And I think that being able to share CRF on the website can be also helpful for people who are trying to get something started. But as you've heard on the call today, there's actually many registries that people may be able to join without going through either without going through IRB approval or with a very light IRB submission process. Thank you.
Okay, thank you, Emmanuel. Congratulations.